Hey everyone, welcome back to Static Pharmacology here on EMTV. I'll be giving you a patient care scenario, and your goal is to develop a treatment plan that emphasizes pharmacological management. For an extra challenge, I'll be putting a 1-minute timer on the bottom of the screen. When the time is up, we'll do a scenario walkthrough, and I'll give you my treatment. Enjoy the card, and good luck.
3, 2, 1.
Abdominal pain complaints make up the vast majority of the patients that we see. Some of these complaints can be benign, however, more significant injuries or illnesses can manifest with GI symptoms. That's why it's important to do a complete physical exam and get a patient history from someone who's complaining of an abdominal issue. Let's go ahead and take a look at the card in a little bit greater detail. You were dispatched to a private residence for a 27-year-old male complaining of severe abdominal pain and nausea. Your patient appears pale and sweaty, and his skin is hot to the touch. He is alert and oriented and reports the pain began 2 days ago, but has become significantly worse over the last 6 hours. He denies trauma, denies any medical history, and denies any history of similar episodes in the past. Physical examination reveals acute rebound tenderness upon palpation of the right lower quadrant of his abdomen, and right lower quadrant pain when the left lower quadrant is palpated. Your partner obtains the following vital signs: blood pressure 108/54, pulse 114, respiratory rate 24, SpO2 98% on room air, temperature 101.8 degrees Fahrenheit, and a blood sugar of 117. So what's going on here? Well, this patient is exhibiting 2 out of the 3 symptoms most commonly seen in individuals with an acute appendicitis. The constellation of symptoms for appendicitis includes nausea and vomiting, anorexia, or the inability to eat, and severe right lower quadrant abdominal pain. So what is appendicitis? Appendicitis is inflammation of the appendix. The appendix is a small, hollow organ structure attached to the cecum of the large intestine. Some research has suggested that this organ was in place from earlier evolutionary times in order to help facilitate the digestion of cellulose. More modern research, however, contends that the appendix is a reservoir for important or essential gut bacteria. Whatever its purpose, appendicitis is a very common medical complaint. Appendicitis can be caused most commonly by an obstruction to the appendix, usually due to fecaliths, small pieces of solid stool matter that simply plug the inlet. These fecaliths will then compress the walls of the appendix, causing a reduction in blood flow and ischemia to the organ. This is the mechanism present in most cases of necrotizing appendicitis. As the appendix becomes more and more inflamed, it will enlarge and then eventually make contact with the peritoneal wall. This is what causes the right lower quadrant abdominal tenderness upon palpation. Common physical findings present in acute appendicitis include McBurney's point tenderness. McBurney's point tenderness is described as a maximal tenderness that is present at 1.5 to 2 inches from the anterior superior iliac spine on a straight line to the umbilicus. Another physical sign that this patient is manifesting is Rovsing's sign, and this refers to pain in the right lower quadrant during palpation of the left lower quadrant. Sometimes this is also called indirect tenderness. This is indicative of right-sided local peritoneal irritation. If left untreated, this patient risks perforation of the appendix and contamination of the abdominal or peritoneal cavity. Definitive treatment for appendicitis historically has largely relied on surgical removal called an appendectomy. However, more contemporary, non-operative management strategies, including antibiotic therapy, have been used with some success. Patients managed non-operatively for appendicitis must meet certain criteria and cannot possess the presence of a perforated appendix. Management of this patient in the field is largely symptom control. However, you must recognize and exclude other more significant pathology before considering this to be an appendicitis, to be the likely cause of this patient's symptoms. It is also important to determine if this patient has a potential for a surgical intervention so that you can plan an appropriate transport destination. Let's go ahead now and move on to the treatment. Now, just like with all my other cards, I'll begin treatment by regurgitating the mantra. Scene safe, BSI, IV O2 monitor. Now, as I'd mentioned before, this patient's care pre-hospitally is largely going to be symptom management. In-hospital acute care will also include the administration of antibiotics. But pre-hospitally, we could begin by administering ondansetron for the nausea. This is dosed at 4 milligrams, given IV push. Pain management is also a consideration for this patient. I could administer fentanyl at 50 to 100 micrograms given IV push, or morphine, 4 milligrams IV push. For non-opioid pain management, you could also administer ketorolac. Ketorolac is an IV NSAID, long considered contraindicated for a patient who has a potential to be a surgical candidate. However, most contemporary surgeons are okay with the administration of ketorolac for pain control. You'll then administer IV fluids, such as normal saline or lactated ringers. And finally, rapid transport to an appropriate facility that has surgical capabilities. And that's it. If you enjoyed this card, please make sure to head over to my channel for more. And while you're there, make sure you like and subscribe, and check out my other playlists, such as Static Cardiology or Paramedic Pathophys. I also have new merch for sale, so please make sure you check that out. Every sale goes to support my channel. Until I see you next, stay safe, keep washing your hands, and have a good rest of your night.